Yes.
Dr. Dempsey, just a handful of further matters. If we could start by going back to your witness statement. So, Sally, could we have WITN 556-0001 and go to page 37? You say at the top of the page, paragraph 74.1, in response to a question about the treatment of previously untreated patients, you refer to the use of DDAVP or cryo for those with mild haemophilia or von Willebrand's, factor concentrate for moderate or severe. And then you say this: to limit donor exposure, we would aim to set aside one batch of factor for their regular use. I think you told us this morning, Dr. Dempsey, that in practice, batch dedication wasn't a very useful option. But I thought I should remind you of that sentence and just ask you to recall what was or wasn't done in that regard.
Well, it didn't really happen. There were times when we thought we might get it established, but for a patient, but it didn't work out. One way or another, the batch got mislaid and used, and it didn't seem to work. I have limited, I had limited confidence in its ability to make a major contribution to keeping people infection-free. Depend on the batch you chose, I suppose.
And then, still on the statement, but on a different topic, if we could go to page 9, please, Sunny. At the bottom of the page, in response to a question posed about the relationship with pharmaceutical companies and their influence, you say, I had occasional visits from sales representatives of commercial companies, but these visits did not influence my decisions on which product to use. But first of all, can you assist us in understanding why, and you've told us this morning already, you had conversations with pharmaceutical representatives about hepatitis risks in relation to their products. Can you assist us in understanding why you were receiving visits and having these discussions with pharma reps when it was Dr. Main who did the ordering?
Well, I suppose the reps like to say they've visited so many people, and it looks good when they go back to base and they've covered all the options. I didn't do the ordering, and I had a very limited patient group to utilize their products, but they still came to visit me, and I felt that I was keen to hear what they had to say, and I was keen to be civil to them when they came round the door looking for a short talk. That really underlies what was going on. They didn't come too often, and as I say, I wasn't the one who did the ordering, and I guess they knew that, or I made it fairly plain to them. So I was happy to sit and listen to what they had to say, but I didn't feel that I was being placed in a compromising position at any time.
Can you recall which companies, of the companies producing factor VIII concentrates, which companies you had these occasional visits from?
Well, I think it was mostly Armour, as I recall. I think it was mostly Armour.
And do you recall the names of any of the individual reps?
Well, I can visualize him, but I can't remember his name now.
Did you recall a visit from a Christopher Bishop for Armour?
Not really, no.
Were these ever joint visits with Dr. Main? In other words, was she present on some of these occasions?
Never. She never came with them to visit me. They would always visit her on their own, yeah.
And you say in the statement the visits didn't influence your decisions on which product to choose. And in terms of choosing between different commercial products, I understand you said you took whatever was in stock. But would it be right to say that the visits did influence your treatment choice because they reassured you that commercial concentrates were, from a hepatitis perspective, safer than they previously had been?
Yes, they influenced me in that respect. But I had that opinion anyway. Before they came to visit me, I think I had established the idea that commercial concentrates were safer than they had been in the mid-70s.
We can take the statement down, thank you. Is it right to understand, in terms of the treatment decisions you took in the early 80s, that as a result of the one patient you described with an internal bleed in 1981 who did not respond well to cryoprecipitate, you decided to transfer your entire cohort of moderate patients to commercial concentrates, notwithstanding that they'd not previously been treated with those concentrates?
That's right. But, you know, I always had doubts about cryoprecipitate, and I think my feeling was that many people did. And I think that experience, which shook me to the core, tipped me over the edge as far as cryoprecipitate was concerned, and I decided I really ought to be more circumspect before a similar episode occurred, and there was a more unwelcome outcome.
Looking back now, was that in retrospect the wrong decision to take?
Well, looking back now, I would think that perhaps the best decision I should have taken was to go on to the NHS material, given what was going to develop. So if I had to do it again, I'd have gone on to the NHS material. The thrust among the hemophilia treaters, was to maximize and intensify treatment of bleeding episodes into joints. The aim and object was to preserve the joint function, and you really have to work at it to do that. And failure around a joint was a tragedy, because the patient was going to have that joint with them for the rest of their lives. And the feeling was that to intensify and maximize treatment on joints that were causing trouble, the feeling was that really concentrate was the best way to do it. So the pressures were on to look after the joints, and the best way to do that was with with concentrate. And that was the feeling I took from many meetings among the leaders in the field.
Once the arrangement with the PFC was underway in 1982, why did you not then switch immediately to SBBTS product? Why did you continue using commercial products until June 1983?
Because the haemophilia community was still, the haemophilia organisation, the UK HCDO, still hadn't come round fully to the idea that commercial concentrates were responsible for the emerging AIDS problem. There was still resistance among the haemophilia treaters about the significance of concentrate and the emerging AIDS problem. And I suppose I absorbed some of that, and probably that delayed the conviction that the concentrates were responsible, and that really action should be taken to stop using them and switch over to the Scottish product.
On the issue of hepatitis C testing, were you aware that Dr. Main was sending samples to London for testing for hepatitis C as early as 1990?
No, I don't think I was. I think she contacted me when she thought that I should slot in to the arrangements she had made with London. I don't think it was 1990 she got me to send the samples over. I think it was more likely to have been 1991. But I couldn't honestly be awfully sure about the dates. That's as much as I can recall.
I asked you this morning about whether it might have been more appropriate to have a more nuanced approach in relation to concentrates and cryoprecipitate rather than swapping all the children onto concentrates, the moderate children. And you indicated that using both concentrate and cryoprecipitate for a patient would be something to be avoided. Why would that be the case? If there's a risk from concentrates that's greater than the risk from cryoprecipitate in terms of hepatitis, why not with an individual patient treat them with the safer product, cryoprecipitate, if that's effective for the individual presentation on that day, and if in 4 months' time there is an internal bleed which requires concentrate, then use concentrate on that occasion?
Well, I think the feeling was that once you'd used concentrate, you probably had compromised the patient with regard to non-A, non-B hepatitis anyway. So my feeling, it may be coloured by subsequent knowledge about non-A, non-B hepatitis, or hep C actually, was that most of these concentrates were probably contaminated. And that once you'd used them, you'd probably have exposed the patient to hep C, and they'd probably been exposed to the virus at that stage. So going back to cryoprecipitate wouldn't do them any good from the safety point of view, and you would deprive them of the benefit of concentrate if you perceived concentrate to have special benefits when it came to treating bleeding episodes. So you were probably getting the worst of both worlds by mixing them together.
In terms of the conversations you had with patients or with their parents, pre-aid, so when you were discussing the change to cryoprecipitate, from cryoprecipitate to concentrate in 81, 82, did you, as far as you can recall, tell the parents in terms that concentrate was riskier in terms of liver disease?
Oh yes, I would have, yeah.
Did you tell them what you just told us, that once you've given concentrate, you have to assume that the patient has been exposed and may well have contracted hepatitis? In other words, giving them concentrate was giving them hepatitis.
I don't know that I said that to them. I've said a moment ago that what I think about concentrate now may be coloured by what we subsequently learnt about it. At the time, I may not have appreciated that every time they got concentrate, they were exposed to
I see.
hepatitis.
So you're answering the nuanced approach, not because of what you thought at the time, but because of what you think you know, having looked back.
Yes, it's what I think I know now. Yes, no. What I knew then was different. I don't think we knew that every batch was contaminated then. No, I don't think that. No.
Well, can you help me with this? Of the moderate haemophiliacs that you actually had, were there any who did not contract hepatitis C?
I can't honestly remember. There were a small number of people who didn't contract it, but they would have been primarily in the von Willebrand mild hemophilia category. I can't think of anybody in the moderate who didn't contract it.
Thank you.
And in terms of the conversations you were having with parents, given that, as you've told us, you thought that concentrate was the more effective treatment, would it be right or fair to assume that you would have been telling parents of your strong view that that concentrate was a better treatment for their child than cryoprecipitate?
Well, I would have told them my experience and what I thought was the general experience of the haemophilia treating community vis-a-vis concentrate versus cryoprecipitate. I mean, but I would have emphasized that the cryoprecipitate could work, maybe not as effectively, but I did say that it was going to be less. There was going to be less risk of infection in the short term with the cryoprecipitate.
In terms then of your discussions with parents about AIDS, why? As I understand your evidence this morning, you indicated that was a conversation you really started having in mid-1983 following the UK HCDO advice and the switch from commercial to SBBTS product. Do you think you should have been telling patients or their parents about the risk of AIDS really from late 1982, when you had no real doubt yourself that there was the possibility of transmission?
Well, I suppose in retrospect, maybe I should have told them earlier. In retrospect, of course, there was a cloud of unknowing then that covered the haemophilia treating community. Things were not as clear-cut then as they appear now. With the knowledge we have now, yes, probably we should have been maybe held these conversations earlier, maybe. That's me. I'm not speaking for anybody else in this context. Me alone.
And then in relation to the SBBTS concentrate, you said you had confidence in it in terms of the risk of transmitting AIDS when you made the switch in or around June 1983, a confidence which ultimately turned out to be misplaced. Was that confidence based upon an assumption that it was safe because it was made from volunteer donors in the United Kingdom, or did you have any particular information about the measures being taken in Scotland or any particular assurances about the PFC concentrate that you relied upon? No, I had no information from PFC about it. It was related mainly to the fact that the cases of AIDS, which had occurred in relation to blood products, had occurred in relation to commercial concentrate. And I saw the AIDS problem as being related to commercial concentrate. And that is primarily why I probably thought that the SBBTS material was safe, in common, of course, with a lot of other people who also felt the same. So those are the questions I'm proposing to ask from the suggestions from core participants. I'm just going to check whether there were any from... None from Dr. Dempsey's own representatives. Do you have any questions for Dr. Dempsey?
No, those I've had, I've asked along the way.
Dr. Dempsey, is there anything you would wish to add?
I only want to say that I appreciate the pain and suffering that these conditions have caused to the haemophilia community in Britain and Northern Ireland. And I realise it's pain that continues to this very day. And certainly I regret that any of it ever happened.
sir.
Well, can I thank you for evidence which in many ways has been really quite informative and enlightening. Thank you for your time and for being here with us today.
Thank you.
So that concludes the evidence for this week, sir. We're not sitting next week, and then we resume
On the Monday.
on the Monday.
And we need to make a
21st,
note of that because people will be used to us
Yes.
starting on a Tuesday.
We do.
That,
And
that week we're doing Monday to Thursday.
We are, and that week and the following week, the precise dates and details are on the inquiry website, but the focus is on transfusion practice from the perspective very much of what was happening in the hospitals, having heard the evidence we have over the last few weeks about the transfusion centres themselves.
Yes, well, we heard quite a lot about some of the aspects of transfusion practice, and now we're going to hear it from those who are actually doing the job at a clinical level.
Exactly.
Yes. Well, thank you very much, and thank you again. And that's it for this week.